Hi everyone, this is Dr. Windsor. Welcome to the first half of our discussion of specialty populations. In this lecture, I will cover the first two specialty populations, pediatric and obese. Let's take a look at what we'll learn from chapter 4. After studying this chapter, we should be able to compare and contrast different surgical care considerations for a variety of specialty populations. We should also be able to evaluate the physical and psychological needs of each specialty population, as well as compare and contrast the intraoperative considerations for each specialty population, and evaluate the role of the surgical tech in regards to each of those specialty populations. We should also be able to assess the ethical commitment that's required of the SurgTech as it relates to these populations and their care. And lastly, determine the general needs associated with each of those special populations. So let's go ahead and dive in by starting to talk about the reason we need to know stuff about specialty populations. And the reason we're talking about specialty populations is because these patients have special intraoperative needs. And as the surgical technologist, we need to understand what those needs are so that we can respond appropriately before, during, and after surgery. Although there are other populations that have special needs, we will focus specifically on pediatrics, obese, diabetic, pregnant, immunocompromised, disabled, geriatric populations, substance abuse populations, trauma populations, as well as post-traumatic stress disorder populations. So let's talk about the pediatric patient first. It's important to note that pediatric patients are referred to as neonates for their first 28 days of life. Then from 2 to 28 months, we refer to them as infants. Now, the toddler stage is 19 to 30 months. And once the little ones are 31 months old, we refer to them as preschoolers. Then from the years of 6 through 12, they are referred to as school age. And lastly, they are considered adolescents from 13 to 18 years of age. So, pediatric patients span the first 18 years of a patient's life. Children have surgery for the same reasons that anyone else does. It could be a congenital abnormality, something they're born with, a disease, or a trauma. However, this does not mean that children are little adults. They have anatomical and physiological differences that significantly impact the surgery and the surgical team. So be sure to familiarize yourself with the information in tables 4-1, 4-2, and 4-3 concerning pediatric anatomical and physiological considerations, as well as heart rate ranges and respiratory rates. It's important to note that each step of development brings different challenges. For example, infants startle really easily, and as a result, we want to work as quietly as possible when they are in the operating room. They also lose heat and fluids very quickly. So for this reason, we want to keep them as warm as possible, limit their exposure to the operating room, and return them to their caregivers as soon as possible. Preschool and school-age children will have some understanding, but a very limited understanding of what is happening to them. So you'll need to use very simple language to communicate with them. It's also important to be as honest as possible without scaring them. You want to avoid telling them that something isn't going to hurt. Instead, tell them that they're going to feel a pinch. When we have a pediatric patient in the operating room, our main focus is going to be on meeting their physiological needs. Think back to Maslow's hierarchy of needs. That most basic bottom level is the physiological needs. So we're focused on those. As I mentioned previously, we want to return our patient to their caregiver as soon as possible. So that means we need to know our jobs really well, and we need to work efficiently in the operating room so that the surgery goes smoothly and it's completed in a timely manner. So what can we do to reduce a child's anxiety level? Well, first, we can let them bring a toy or maybe a stuffed animal into the operating room with them. Some facilities give out teddy bears, while others, depending on the age of the child, take the patient back to the OR in like a little wagon or something like that. It's also a good idea to introduce the child to the individuals that will be with them in the operating room. Additionally, they might let the child get familiar with the environment by taking them on a little tour. It might also be a good idea to allow the caregiver to bring the child back to the OR or to accompany them back to the OR and stay with them until they're asleep. Lastly, the caregiver should be allowed to rejoin the child in the post-anesthesia care unit, the PACU, as soon as the first set of vitals have been taken. Now I want to spend some time talking about pediatric monitoring. It's important for us to understand that there are distinct differences that exist between pediatric and adult patients. And there are 4 critical parameters to monitor for the pediatric patient, and those include temperature, urine output, cardiac function, and oxygenation. So let's discuss temperature first. Neonates in particular do not have the ability to shiver like we do. That doesn't develop until like the first year of life. So this means that they are unable to warm themselves when they are cold. They also have very little body fat and as a result lack thermal insulation. I have some that I could let them borrow some spare thermal insulation. But they also lack lean body mass, so they don't generate heat as efficiently. So all of these things, coupled with the fact that they lose heat very easily, especially from their big old noggin, and the OR is a really cold environment, they can get cold very quickly. So this puts them at a higher risk for developing hypothermia. And oftentimes we will warm up the room a bit before the patient is brought in. Needless to say, monitoring the pediatric patient's temperature is really crucial. Temperature can be monitored via the rectum, esophagus, ear, axilla, which is the armpit, or skin. However, the skin is the most common method that we use in the operating room. Although we can use devices like radiant heaters, warm air and warm water blankets, the best thing to do is to keep the little ones covered and wrapped as much as possible, as well as limit the time that they are exposed to the environment of the operating room. So that means OR time, surgical time. Now, urine output is an important component of fluid management for all patients across the board. Typically, neonates and infants are not catheterized because there is a higher risk of trauma to their little urethra. If fluid output needs to be monitored on a neonate or an infant, what we're going to do is use a special bag that we place underneath the patient's bottoms to catch the urine and measure that output. An appropriate urine output for the infant or neonate is approximately 1 to 2 milliliters per kilogram per hour. So if we have a patient that weighs 10 kilograms, their urine output should be approximately 10 to 20 milliliters per hour. Cardiac function is monitored with an arterial line, and that arterial line is typically inserted into the radial artery, or they can place a central venous catheter into the jugular or subclavian vein. This is because the blood pressure cuff and stethoscope can produce inaccurate readings due to the variance in cuff sizes. Monitoring oxygen levels, again, is standard for all patients. So back in the day, and sometimes we still do this, we measure blood gases when with a test called AGBs, arterial blood gases, where they draw some blood and they look at the gases in the sample. But there's been this amazing invention called the pulse oximeter, and this is a lot easier way, and it's a less invasive way to measure oxygen levels. So unless we have a really sick patient, we typically don't do ABGs, but if the patient has a radial arterial line already, then they might choose to do that. So let's talk about two different types of shock that are commonly seen in pediatric patients: septic shock and hypovolemic shock. Now we see it in adults too. Septic shock is the most common type of shock seen in infants and children. Septic shock is a result of some sort of infection that has infected the blood, and now it's in the patient's entire body. We call that septicemia. Typically, septic shock is caused by some type of gram-negative bacteria. Remember, gram-negative bacteria are those bacteria that have a really a thin cell wall, and they don't really hold the stain really well, so they end up looking like a really light pink. Examples of those are E. coli, which lives in our intestine, Pseudomonas, and H. pylori. So an example of this: E. coli lives in our digestive tract, and if there is a perforation in the intestine, that can allow for that bacteria to leak out into the abdominal cavity. We call that the peritoneal cavity, and this can cause inflammation of the lining of that cavity, which is called the peritoneum. So inflammation of the lining of the peritoneal cavity, we refer to that as peritonitis. Other causes of septic shock can be from a urinary tract infection, a UTI, or an upper respiratory infection, a URI, or a contaminated intravascular catheter. Septic shock also presents with a reduced blood volume. Treatment is going to include giving IV colloid solutions, and this solution is going to help beef up the blood volume. They're also going to give antibiotics to fight the infection, and sometimes even after they've treated the little one with colloid IV solutions, the patient's blood volume is still too low, so they might give something called dopamine to further increase cardiac output. So that's septic shock. Let's talk about hypovolemic shock. If we dissect the word hypovolemic, remember when we're decoding a word, we start at the end with the suffix, which is IC, which means pertaining to. Now, hypo means low, and volumen is the medical term for a volume. So here, hypovolemic means pertaining to lower volume. So the patient is experiencing fluid loss. And when anybody experiences fluid loss, that can cause a decrease in the blood volume, which is going to cause a decrease in cardiac output. There's less blood to pump around. And for little ones, dehydration is the most common cause of hypovolemic shock. Some things that we should look for are bradycardia, which is reduced heart rate, as well as poor tissue perfusion. So maybe we're not getting bleeding at the site, maybe the tissue's looking a little cyanotic or bluish. That could be a sign that baby is in hypovolemic shock or has hypovolemia. And the treatment here is to give fluids like sodium chloride intravenously. So it'll help us to better understand the management of fluid and electrolyte balance of the neonate and infant if we know how body fluids change before and after birth. So when a baby is born, about 78% of its body is water. Also, 45% of that water is what we call extracellular. So that means it's in between the cells. It's in the tissue. All right? So before birth, the fetus has a constant and readily available supply of water and electrolytes from mom, right? And electrolyte homeostasis or balance is largely a function of mom and the placenta's ability to regulate those substances, water and electrolytes. Now, after a baby is born, the newborn has to rapidly assume responsibility in its own body, right? It's not connected to mom anymore, for fluid and electrolyte homeostasis. And it doesn't really have the ability to control its intake. It has to get food from mama or its caregiver, and its kidneys aren't functioning at their highest capacity yet. They're still developing, right? So because their kidneys are still developing, it's difficult for them to compensate for fluid and electrolyte perturbations in an environment in which water and electrolyte losses are much more variable, because now mom's not controlling anything, right? The baby's not connected to mom, and now it's out and it's its own entity, and it's having to do these things for itself. And if it's thirsty, it's not like us can just get up and go get a drink, or if you're craving salt, eat some. So this is further exacerbated in the premature neonate because their kidneys are even more underdeveloped. And this can cause them to secrete more sodium or salt than they normally would. Now, what we know from studying the body and its physiological processes is that anytime salt moves, water moves with it. So if the kidneys are underdeveloped and they're not holding on to salt, they're excreting salt, then water is going to follow, and they're going to have increased urine output, which means they're going to have decreased fluid volume. All right? Another way that patients, pediatric patients, especially infants, lose water is through breathing out, right? Or our breath, if we hold a glass up to a mirror, let's say, up to our mouths and we breathe out, it gets like foggy, right? That means that the air that we're breathing out is humidified, and then they also lose water through their skin. And this water loss through breath and skin is referred to as insensible water loss. So 10 days after birth, the neonate has the same anaerobic and aerobic bacteria. Anaerobic bacteria, bacteria that doesn't like air. Aerobic bacteria that does, living in the GI tract just the same as we adults do. However, their immune defenses are still underdeveloped, and that puts them at a higher risk of developing an infection. And just a side note here, it is imperative, not just with pediatric patients, patients in general, but with these specialty populations even more so, that our sterile technique is top notch, folks. The first sign of infection in any of us is typically a fever, and it'll present the same way in the little ones as well. The most common site for post-op infections are the lungs, surgical wounds, urinary tract, and vascular access sites. So what does that surgical treatment look like? Well, it typically includes something called a debridement, where we would remove any devitalized, dead, necrosing tissue from the wound. We may also put some packing or some sponges soaked in antibiotics into the wound. If the wound is infected, we're not going to sew it up. So that little baby is going to have an open wound on them, and then they're going to have to get their dressings changed frequently, and sometimes that's really painful. So they might have to be brought back to the operating room and put under anesthesia for us to do the dressing changes, or potentially they might have some sort of wound vac that would need to be changed as well. If there's an infection due to catheter placement, that's going to require the removal of whatever catheter, whether it's a venous catheter, or urinary catheter, or whatever the case may be. Now, it is the standard of care to administer prophylactic antibiotic treatment prior to surgery, across the board pretty much. So treatment, antibiotic treatment is given before surgery, an hour or 2 hours before, and then it's continued for 1 to 2 days post-op. Now, with little ones, we want to make sure we don't give them sulfonamides or chloramphenicals or tetracyclines, because these have really harmful side effects to baby. And in addition to that, most antibiotics are associated with something called enterocolitis, and that's what you see in this little one here on your screen. And this is because antibiotics have a tendency to kill off the helpful bacteria in our GI tract. And the helpful bacteria is what keeps the nasty bacteria, the harmful bacteria, in check, right? The bullies are kind of allowed to run amok, and that allows for the proliferation of that harmful bacteria. An example of that is Clostridium difficile. So if you've ever heard of C. diff, that's what they're talking about there. So let's talk a little bit about caloric requirements. Just briefly, the takeaway here is that the caloric requirements for children is much higher than it is for adults. And when pediatric patients have surgery, their caloric requirement increases by 20 to 30%. So as a result, infants typically receive a feeding tube post-operatively for procedures if we're operating on the gastrointestinal tract. So moving on to talk about accidents, trauma, and key differences in treatment. According to the text, accidents are the #1 cause of death in children ages 1 through 15, and according to the Centers for Disease Control and Prevention and the National Center for Injury Prevention and Control, 2,800 children ages 1 through 14 died from an unintentional injury. So Trauma is the most often the result of blunt trauma, and head trauma is much more common in children than adults. It could also be from a motor vehicle accident, falls, bicycle accidents, drowning, burns, poison, and child abuse. A side note here, us as surgical techs, we are the extra eyes and ears in the operating room. So it's really important that we stay alert and we report anything that is unusual to the nurse, the anesthesia care provider, or the surgeon. So let's talk about key differences in treatment. With the little ones, they're not going to be able to communicate well, or if they're a neonate or infant, they're not going to be able to communicate at all with us. So that can pose a problem because they're not able to tell us exactly what's wrong with them. They might also give us misleading information. If you say, does your tummy hurt? They might say, but their tummy really doesn't hurt. So they might not be the most trustworthy source in some regards. They may also display signs of regression with or without their parents. There are also metabolic and nutritional differences. Again, I talked about the caloric intake. It is increased for our pediatric patients. Post-operative metabolic management is also critical. Metabolic refers to the total of all chemical changes that take place in a cell or in our bodies to produce energy and basic materials that we need to live, right? To live. A small amount of blood loss can also have really serious consequences. If I were to lose, 8 ounces of blood, that's not going to be nearly as critical as if an infant were to lose that amount of blood. Then, as I mentioned previously, they lose water and heat very quickly. And if they are hypothermic, that's going to increase the effects of something called acidosis. And acidosis is when there is an excess of hydrogen ions in the body that causes the blood pH to be too low. Typically, we want blood to be like 7.35 to 7.45 on the pH scale, and if it drops below 7.35, that would be considered an acidotic situation. And lastly here, vomiting. Vomiting can lead to hypovolemia. It can also increase the risk of aspiration, which is where contents comes out of the stomach, up through the esophagus, and it gets inhaled into the trachea and perhaps into the lungs, which can cause pneumonia as well. And so that is some key differences in treatment in a nutshell. And next we're going to talk about some general principles of pediatric emergency treatment. So to wrap up our discussion of the pediatric patient, we're going to talk about priorities, trauma during birth, and child abuse. So let's talk about priorities first. When we are treating a pediatric patient in an emergency situation, and sometimes this is going to be handled in the emergency room or emergency department, but airway management is the first priority always. We want to get control of the airway because if there's no breath, there's no life. So we want to focus first on airway management. If there's any foreign objects in the airway, we want to make sure that those are removed, and we also want to stabilize the cervical spine. Now, once we have control of the airway, if baby or pediatric patient still is struggling to breathe, that might be a sign that there's a pneumothorax. And that means that there is an outside opening into the chest cavity. And our chest it is a negative pressure environment, so it's not subjected to the weight of gravity of the regular world that kind of holds us to the ground. So if there is a hole in the chest cavity, air is going to rush in and fill that space, and the lung isn't going to be able to inflate. So in that case, a chest tube would need to be placed. Next, IV, intravenous access. We have to obtain that. And some of these things might be happening simultaneously. Again, if it's in the emergency room or the OR, they might be doing 3 or 4 people might be working on this patient doing these things simultaneously. It might be difficult in little ones to start an IV in a peripheral vein like they do for adults, so they might have to do a cut down and put the IV in the saphenous vein down at near the ankle. That's what's recommended. So they're going to start fluids once they get IV access, and then also important to control bleeding. Remember, a little bit of bleeding can have catastrophic consequences for the pediatric patient. So let's move on and talk about trauma during birth. So now we have this most fantastic invention called ultrasonography. And you might have just heard it called ultrasound. It's the same thing, and that has really allowed us to get a good idea of what's going on as the fetus is developing inside mom. It's also helped us to reduce the occurrence of traumatic injury to the neonate, but a small percentage of births still result in injury, and those injuries could be to bones or internal organs or potentially nerves. The clavicle or the collarbone is the most common fracture due to something called shoulder dystocia. And this is where the shoulders, the head comes out, but the shoulders get stuck behind mom's pubic bone, and that can also result in something called brachial plexus palsy, which is kind of within the armpit there. There's a bunch of nerves there, and if those get pinched or pushed or pulled, that can also cause injury there. Injury to the facial nerve can happen, and that's typically due to direct pressure on the face from mom's pubic bone, or if they had to use forceps to coax baby out of the birth canal. Injuries to internal organs like the liver, the spleen, the adrenal glands, that's often a result of pressure on the fetus's abdomen as it passes through the birth canal. There can also be an injury to the sternocleidomastoid, which is the muscle that's responsible for turning your head left to right, left to right. And if that does occur, a blood clot or a hematoma can occur, as well as something called torticollis, and that is a contracted muscle. So for some of these injuries, surgery may be required to treat them. Lastly, here on this slide, I want to talk about child abuse. Now, child abuse can incorporate any type of mental, physical, sexual, nutritional, verbal, or delayed treatment type abuse. And often the child will have several injuries, or they will have several healed or healing injuries. And oftentimes surgery is going to be required to treat injuries such as broken bones, lacerations, burns, head trauma, and visceral injuries, which would be the internal organs. So now that we have a better understanding of the pediatric patient, let's talk about the obese patient. Now, morbidly obese refers to a patient whose body weight is more than 100 pounds greater than their ideal body weight. Increased morbidity and mortality is due to the physical difficulties associated with carrying all of that extra weight. Complications and morbidity will vary with the severity of the obesity. So let's talk about physiological and disease conditions related to obesity. I have several listed here for you, so we'll go through them one by one. The first one is myocardial hypertrophy, and this is just a big word that means enlarged heart. Enlarged heart. And this is due to the heart having to work harder because it has a bigger body to supply blood and oxygen to. And this can lead to something called congestive heart failure, or CHF. And CHF is when the blood backs up because the heart is not working properly, and fluid can actually build up in the lungs and lead to difficulty breathing or shortness of breath. Coronary artery disease is also another condition related to obesity. Remember, the coronary arteries are the arteries that supply the heart muscle with blood and the much needed oxygen for it to do its job. So if the heart muscle can't get the oxygen that it needs, then that could lead to cardiac arrest. Hypertension, vascular changes in the kidneys are also some things that can be more common with the obese patient. And in individuals with hypertension, that means that there's a lot more pressure on the walls of the vessels. And this takes a real toll on our kidneys, and it can cause damage to the kidneys. And because of that, they're not able to properly regulate fluid and electrolyte balance. Varicose veins and edema in the lower extremities can be due to poor venous return, and blood can start to pool in the veins. Remember how veins work. Veins work by muscular contraction. That's how blood in the veins gets back to the heart. They have these little valves, and as we move our skeletal muscle, it squeezes the veins and pushes blood up past these valves. And the valves, when they're working properly, keep the blood from flowing in the wrong direction. But in these situations, if blood is pooling in the veins, it's going to damage the integrity of the valves, and the valves aren't going to keep the blood from flowing in the wrong direction, and that is what leads to varicose veins. Something else we see is pulmonary complications. Obese individuals typically have difficulty breathing. They can have shortness of breath. They're prone to sleep apnea, and their lungs don't inflate as well because they have a lot of weight on their chest. And so this can increase the risk of post-operative pulmonary infection and embolism. We also see liver and gallbladder disease, osteoarthritis, which is the degeneration of the ends of the bones, diabetes mellitus, pituitary abnormalities. Remember, the pituitary is the master gland, and its hormones pretty much control everything that happens in our body. So if something's going wrong with the pituitary, that could cause a whole domino effect in the individual's body. Other things, arteriosclerosis, right? Hardening of the arteries. And lastly, dysfunctional uterine bleeding. So now that we have a better understanding of the physiological and disease conditions related to obesity, let's learn about some surgical considerations we should be aware of. And I want to start off by talking about transportation and transfer to the OR table. So transport and transfer. Transport means you're bringing them from wherever they are into the OR, and typically this is on a gurney. However, we want to have extra personnel there and available to assist with that transport so that nobody gets hurt. When we are transferring the patient to the OR table, they're probably going to need our assistance. Prior to surgery, in pre-op, patients usually get some sort of cocktail that makes them a little bit sleepy in their IV. And so you're definitely going to need extra moving help to move them from the gurney to the OR table, and then after surgery from the OR table back to the gurney. You might need to have some sort of mechanical lifting device. Something else to think about is the patient's dignity. Always, always, always. Not just with obese patients, but with all patients. We want to give them their dignity. We don't want to expose their bodies any more than is absolutely necessary. So we want to keep them covered, give them their respect. And once we get them over to the operating room table, we want to make sure we put some pillows under their knees, and then we put that safety strap 2 inches above their knees. So let me just give a little side note here. When transferring a regular sized patient, we typically need 4 people. In a situation with an obese patient, I would say have at least 6 people, if not more, for extra moving help. Something else I want to talk about is the IV insertion and administration of fluids. Now, majority of the time when individuals come into the OR, they already have their IV in place. It may have been or may be a difficult insertion. It might also be a difficult intubation. So we can expect an increased anesthesia recovery time. Obese patients tend to have poor lung function and poor blood supply to their adipose, so it's going to take them longer to wake up, right? When we're positioning the patient, again, we want to have extra help, 6 people or more, and we may need to put 2 operating room tables together to accommodate the patient. Something else that is important to think about is the orientation of the OR table. In its normal orientation, there is a weight limit, and let's say it's 1,000 pounds, but if we're going to reverse the OR table and have the patient on that reduces the weight capacity by half. So we might need a special bariatric table and special positioning devices for our bariatric patient. Also, the patient is going to need a grounding pad. So we want to make sure that we are really diligent about checking the skin integrity and not putting that grounding pad over wrinkled skin or skin that has folds in it. Okay, instrumentation. We need to anticipate the need for longer instruments, larger retractors, longer hemostats, longer ties, and we can probably expect a longer operating time. Delayed healing. Adipose does not heal nearly as well because it has a poor blood supply. If the patient has diabetes, this can also slow the healing time. Bariatric patients are also at a higher risk of dehiscence, which means a part of the wound could come open, or evisceration. The entire thickness of the wound comes open and abdominal contents can spill out. We also want to anticipate some sort of retention devices for wound closure, and I put a couple examples up here for you. The picture that you see on the lefter side is retention sutures and bridges that can help to prevent evisceration or dehiscence. And the other one, those are called Montgomery straps, and they have like a adhesive portion that's kind of sticks kind of lateral more to the sides of the patient, and then they can get laced up, and that helps take the tension off from the primary wound. Now, obese patients are also at a higher risk for post-operative wound infection. I mentioned dehiscence, also pulmonary embolism, anesthesia complications, respiratory failure, deep vein thrombosis, and anastomotic leaks. Anastomotic leaks, that there we're talking about if we've taken out a piece of intestine and we're going to put those two ends of the intestine back together, there is a higher chance that that could be compromised, that anastomosis. All right. The anesthesia care provider may require assistance when placing the obese patient under anesthesia, and they're probably going to put the patient in reverse Trendelenburg. Remember, that's head up, feet down. That's going to shift some of the weight down and off the lungs instead of them laying flat on their backs where all that weight is right on their chest. And typically, obese patients have a lot bigger neck, and so it could be a difficult intubation. It could take some time for them to do that. And because they are at a higher risk of deep vein thrombosis, we want to make sure that we put sequential compression devices on our patient. Now, the patient may also receive some form of anticoagulant medication, such as heparin, to reduce the occurrence of blood clots. While they're recovering from anesthesia, they should be kept in reverse Trendelenburg to facilitate breathing, and we want to get them up and walking as soon as possible to further reduce their risk of blood clots. So we're going to wrap up this half of the lecture on chapter 4 by discussing complications after gastric surgery, gallstones, and degenerative arthritis as they relate to the obese patient. So there are 3 common complications after gastric surgery, and those which the gastric surgeries we're referring to are typically bypass or gastroplasty. Those complications are abdominal catastrophes, internal hernia, and acute gastric distension. So with abdominal catastrophes, these are really difficult to diagnose in an obese patient. We may see acute respiratory failure, and that could indicate peritonitis. If there is a perforation, those need to be treated surgically, and that is an urgent type procedure. Now, internal hernias, if those are left untreated, they can result in dead bowel. And the primary symptom is pain around the umbilicus or the belly button. And again, surgery is going to be required to repair that. And then lastly, acute gastric distension. So what happens here is gas can get trapped in the distal portion or the lower portion of the bypassed stomach. And this can lead to perforation of the stomach. And in this case, emergency surgery is going to be needed to repair that as well. Now, bariatric patients are also, they have a propensity to develop gallstones. And anytime you're doing surgery on a bariatric patient, you should have gallbladder removal kind of tucked in the back of your mind and have the stuff available to perform that gallbladder removal. we call that a cholecystectomy. So be prepared for a cholecystectomy. And then lastly here, degenerative osteoarthritis is commonly seen in obese patients. Again, remember, this is the wearing of the cartilage off from the ends of the bones where they meet and work together. We call that where they articulate, and this can be really painful. It commonly is found in the back, hips, and knees of our obese patients, and this can require a total joint arthroplasty. So we might have to replace their joints because of that. Total hip, total knee, those kinds of things. All right, so this is going to conclude the first half of the lecture regarding special populations. In this half, we learned about pediatric and obese specialty patient populations. So stay tuned for the second half, where we're going to learn about diabetic, pregnant, immunocompromised, physically challenged, sensory impaired, isolation, geriatric, substance abuse, trauma, and post-traumatic stress disorder patients. So there's a lot more to learn, but we learned a lot here, so good job. And thank you for listening, and I will see you next time.